The EORTC study, the boost, no boost, what is it and what have you been doing in this?
Well, the EORTC Boost No Boost study is a very large phase 3 trial for early breast cancer patients, done collaboratively by the Radiation Oncology and Breast Cancer Group. Early breast cancer patients were treated with tumorectomy, so local surgery, then were irradiated on the whole breast to 50 gray, and then were randomized between either no further treatment or a 16 gray boost. And that's the basis of this study.
You were looking at adverse prognostic factors though, weren't you too?
Correct. A sub-study of this is that 1,616 patients were included in a pathological review. So all the pathological factors of these early breast cancer tumors were analyzed and were related to local control with now a follow-up of almost 20 years.
It took a long time, of course, because treatment is very successful. What did you find?
Well, the initial analysis has been done after 10 years, and there were two things mainly related to an adverse local control, so more local recurrences. Age, young age, and a high grade of the invasive cancer. And now we repeated the same analysis after 20 years with the question, do these factors still come out or do we find new factors? And what we found was that young age is still a very significant factor related to a higher local recurrence rate, but now the high grade didn't come out. Now an additional ductal carcinoma in situ component came out. So there's the invasive tumor, an additional ductal carcinoma in situ, and that was the main factor that we found this time.
So this is a sort of new significance for DCIS then? Yes,
and the reason, we asked ourselves the reason why it only came out now and not earlier. And what we found was that the high grade of invasive cancer gives a lot of recurrences in the first 5 years. So it's a factor that you pick up soon in the follow-up after the trial. However, the factor of ductal carcinoma in situ is a significant but less evident factor. So it gives local recurrences more slowly, but it continues to be a negative factor. So you need your longer follow-up to pick up this negative effect.
What have you found then in terms of the significance of using a radiation boost or not using one?
Well, if we specifically look for these high-risk population, meaning patients younger than 50 years of age with a high-grade tumor and an additional component of ductal carcinoma in situ, if they don't get the boost, then they have an ongoing high risk of local recurrence, and this risk can be significantly reduced by the addition of the boost in their local treatment.
You say significance, and I think the hazard ratio is quite impressive.
Yeah, well, we have to be careful. It's an analysis of subgroups, so the numbers get smaller. But if we look at the absolute numbers, then if we analyze this subgroup of high-risk population, then at 20 years there is a 38% risk of local recurrence without the boost, which can be reduced to 9% with the boost. But so, again, small numbers.
Right. And what is this telling us, do you think, about the importance of radiation therapy in treating these patients with early breast cancer?
Well, it tells us a few things. It tells us, first of all, that especially this group needs the higher dose in radiotherapy. So they absolutely need the radiotherapy boost. That's one thing. Within these factors, it's especially also the age that is an important factor. So the young patients need a very good treatment. Another thing that it teaches us is that the trials need to have long follow-up in order to pick up all the factors that in the end become relevant. If you finish your follow-up at 5 years, then you might miss some relevant factors that will come out in the long end, because they have a hazard ratio that's not very high but constant over time.
So this all gives more power to the busy cancer doctor to individualize therapy.
Exactly, and to follow up the patient. And for example, the patients with a high-grade tumor need an intensive follow-up in the first 5 years, whereas patients that have additional DCIS, ductal carcinoma in situ, need a longer follow-up, which is maybe less intensive but needs to continue in time. So
how would you summarize the bottom line message?
Well, the bottom line message is that young patients with a high-grade invasive cancer and an additional ductal carcinoma in situ component have a very high risk for local recurrence, that they need to be analyzed that they need to be followed carefully in time, that they need an optimal, maximalized local treatment, and that the follow-up in studies need to be long to pick up all the factors.